vascular disease is an abnormal narrowing of arteries other than the ones that supply the heart or brain, and it most often affects the ones in the legs. Risk factors include being older than 60 years, smoking, hypertension, hyperlipidemia, diabetes, and metabolic syndrome. The most common underlying mechanism of peripheral artery disease is atherosclerosis, which results in the accumulation of lipid and fibrous material between the layers of the arterial wall. Eventually, the affected artery becomes progressively narrower, and this may lead to pain, ulceration, and even gangrene. Now, most people with peripheral vascular disease actually don't have symptoms until occlusion becomes significant, which is when 70% of the vessel lumen is obstructed. Symptoms include intermittent claudication, which includes pain, numbness, or tiredness in the legs during walking or standing, and is relieved by rest. This is because the blood supply may be enough to meet the muscle needs at rest, but not the increased needs during activity, leading to ischemia. So basically, it occurs when oxygen demand is greater than the oxygen supply. The perceived level of symptoms from intermittent claudication can be mild to extremely severe, depending on the degree of blood supply. Intermittent claudication can present unilaterally or bilaterally as buttock and hip, thigh, calf, or foot pain, singly or in combination. In addition, pulses in one or both groins are diminished, and bilateral aortoiliac disease that is severe enough almost always causes erectile dysfunction. The triad of intermittent claudication, absent or diminished femoral pulses, and erectile dysfunction is known as Leriche's syndrome. Locations of pain depends on the artery involved. Lower aorta or iliac artery involvement causes pain in the hips and buttocks. Iliac or common femoral artery involvement causes pain in the thigh. Superficial femoral artery involvement causes pain in the upper 2/3 of the calf, while popliteal artery involvement causes pain in the lower 1/3 of the calf. And finally, tibial or perineal artery involvement causes pain in the foot. Auscultation of the affected artery can reveal bruits, which are whooshing sounds caused by arterial narrowing. A severe decrease in limb perfusion can result in continuous pain even at rest, which is brought on or made worse by elevation of the involved leg, and is often worse when lying down. Ischemic rest pain is relieved by hanging their feet over the edge of the bed, or, unlike claudication, by sitting or standing, because gravity favors blood flow to the legs. Ischemia may also alter the appearance of the skin, presenting as focal areas of discoloration, or skin color and temperature changes. Elevation pallor is when the foot turns pale when it's raised, and this happens because circulation has to work against gravity as well as the narrowed arteries. Dependent rubor is when the foot turns red when it's lowered, because gravity works to increase perfusion. In addition, lower peripheral pulses, like the tibial and pedal pulses, may be reduced or absent. The most severe stage of peripheral vascular disease is referred to as critical limb ischemia, or limb threat, which is often the result of a progressive chronic disease that affects more than one level of the arterial tree, with poor or no collateral flow to tissues. If the blood supply falls below what is necessary to meet minimal metabolic requirements, focal areas of ischemia can progress to ulcers. Ischemic ulcers often begin as minor traumatic wounds, and then fail to heal because the blood supply doesn't meet the increased demands of the healing tissue. Ischemic ulcers are typically located on the toe joints, malleoli, shin, base of heel, or pressure points. The lesions often appear dry and punched out and are painful, but with little bleeding. Ischemic ulcers are usually associated with other clinical features of chronic ischemia, including hair loss, nail changes like becoming brittle or ridged, and can become infected. Non-healing ulcers can progress to gangrene, which presents a hard, dry texture, usually occurring in the distal aspects of toes and fingers, often with a clear demarcation between viable and black necrotic tissue. If peripheral vascular disease is suspected based on clinical presentation, the initial study is the Ankle Brachial Index, or ABI, which is a non-invasive test that measures the ratio of systolic blood pressure in the ankle to the systolic blood pressure in the upper arm. So say that in the ankle we have a systolic blood pressure of 160 millimeters of mercury, and in the upper arm we have a systolic blood pressure of 125. That would mean that the ABI is 1.28, And that would be totally fine, since an ABI range of 1 to 1.4 is what's considered healthy or normal. Now, if blood pressure values in the ankle are lower than those in the arm, a blockage in the arteries that provide blood from the heart to the ankle is suspected. ABI range values of 0.91 to 0.99 are borderline. Individuals with suspected peripheral vascular disease with normal or borderline ABIs can undergo exercise testing of ABI. This is when baseline ABI is measured prior to exercise, and then the individual exercises, usually on a treadmill at a constant speed, until claudication pain occurs for a maximum of 5 minutes. Then, the ankle pressure is measured again. A decrease in ABI of 15 to 20% is considered diagnostic for peripheral vascular disease. Now, an ABI greater than 1.4 could indicate vessel wall stiffness caused by calcification, so it's usually considered a false negative that needs further investigation with a toe brachial index, or TBI. In general, a TBI below 0.5 is considered diagnostic of peripheral vascular disease. Now, ABI values lower than 0.9 are considered to be peripheral vascular disease. This can be graded as mild to moderate disease if the ABI is between 0.41 and 0.9, and severe disease if an ABI is less than 0.4. If peripheral vascular disease is suspected based on the ABI, the next step is a lower limb Doppler ultrasound to determine the location and severity of arterial obstruction. Advanced vascular imaging techniques like conventional arteriography, CT angiography, and MR angiography are usually reserved for individuals whose diagnosis remains uncertain. Conventional arteriography remains the gold standard for vascular imaging, but it's an invasive procedure where a catheter is placed into the common femoral artery and guided to the affected artery. After that, a contrast dye is injected, allowing individuals to view the arteries with X-rays and record those images digitally. By contrast, MR and CT angiography are non-invasive. In general, CT angiography is obtained first, unless the individual has contraindications to IV contrast, like severe renal dysfunction or an allergy, in which case MR angiography is done. Conservative management of peripheral vascular disease is used for individuals that are asymptomatic, mildly symptomatic, or who can't undergo more aggressive treatments, like the elderly or those with comorbidities. Conservative management includes cardiovascular risk factor reduction, lifestyle modification, and pharmacologic therapies to reduce the risk of atherosclerotic disease progression. Lifestyle modifications recommended include smoking cessation, weight loss, and regular exercise such as walking, which helps with the formation of collateral vascularization. Pharmacologic therapies include long-term antiplatelet therapy with aspirin or clopidogrel, lipid-lowering therapy with statins, and treatment of diabetes and hypertension. Individuals who fail to respond to conservative management after 6 months to 1 year may be referred for possible revascularization. On the other hand, for individuals with critical limb ischemia, revascularization is a priority to establish arterial blood flow. Revascularization options include percutaneous intervention, surgical bypass, or both, and the choice depends on the artery obstructed, severity of disease, the individual's risk for the intervention, and the goals for care. A percutaneous revascularization approach, called percutaneous transluminal angioplasty, is the first choice for individuals with a single short segment of a blood vessel that has uniform occlusion. This type of treatment is less invasive, but it's not as durable as open surgery. The way it works is that a deflated balloon is introduced into the target vessel, and then it's inflated to open the affected vessel, or artery, so that normal blood flow is restored. In some cases, a stent is placed to keep the artery open. Once blood is flowing freely through the artery, the balloon catheter is taken out. Open surgery is reserved for occlusions involving long segments, multifocal, or calcified lesions which reflect more extensive disease and often more severe symptoms. Surgical options for revascularization are endarterectomy, where the artery is opened up and plaque is directly removed, or bypass, where a graft, that's either autologous like the saphenous vein or synthetic, is used to create a new conduit that reroutes the blood supply around a blocked artery. Finally, for some individuals, when gangrene has set in, amputation of the limb may be required to prevent infected tissues from causing sepsis. Alright, as a quick recap, peripheral vascular disease is an abnormal narrowing of arteries other than those that supply the heart or brain. Most cases are asymptomatic until reaching 70% of vessel lumen obstruction. Eventually, the affected artery becomes progressively narrower, leading to pain, ulceration, and even gangrene. The most common presentation is intermittent claudication, which is when there's pain, discomfort, numbness, or tiredness in the legs during walking or standing, and is relieved by rest. A severe decrease in limb perfusion can result in continuous pain even at rest, which is made worse by elevation and lying down, and is relieved by sitting or standing. The most severe stage of peripheral vascular disease is referred to as critical limb ischemia, or limb threat, which leads to painful ischemic ulcers. Non-healing ulcers may progress to gangrene, usually occurring in the distal aspects of toes and fingers, and often with a clear demarcation between viable and black necrotic tissue. The initial study when peripheral vascular disease is suspected is the ankle brachial index, in which a range of 1 to 1.4 is considered normal, 0.91 to 0.99 are considered borderline, and values lower than 0.9 are considered peripheral vascular disease. The next step is a lower limb Doppler ultrasound to determine the location and severity of arterial obstruction. Advanced vascular imaging techniques like conventional arteriography, CT angiography, and MR angiography are usually reserved for individuals whose diagnosis remains uncertain. Conservative management is for individuals with few or no symptoms, and for individuals who can't undergo aggressive treatments, like the elderly or those with comorbidities. This involves smoking cessation, weight loss, and regular exercise, long-term antiplatelet therapy with aspirin or clopidogrel, lipid-lowering therapy with statins, and management of diabetes and hypertension. Individuals who don't respond to conservative management after 6 months to 1 year can have revascularization. On the other hand, for individuals with critical limb ischemia, revascularization is a priority. Revascularization options include percutaneous intervention, surgical bypass, or both. Finally, when gangrene has set in, amputation of the limb may be required to prevent infected tissues from causing sepsis.